In the second lesson of Step 3, we now turn to genetic testing, a cornerstone in the diagnostic workflow for hereditary transthyretin amyloidosis. Genetic screening offers a powerful opportunity for early diagnosis by enabling targeted follow-up of individuals who carry pathogenic mutations in the transthyretin (TTR) gene, even before the onset of overt clinical symptoms. Now we will explore the phenotype categorization by genotype. We will start with the genotypic diversity and clinical presentation. Hereditary transthyretin amyloidosis demonstrates a wide array of clinical manifestations. These variations are closely linked to the specific TTR mutation involved. However, the expression of these phenotypes is not determined by genotype alone. Individual factors, family history, and geographic background also play substantial roles in modifying how the disease presents. To facilitate clinical decision-making, a ATTRv is typically grouped into three major phenotype categories. A neurologic dominant phenotype, often associated with early onset mutations such as valine 30-methionine, Val30-Met. A cardiac dominant phenotype, commonly seen in variants like valine 122-isoleucine, Val122-IL, and a mixed phenotype which includes features of both neurologic and cardiac involvement. Let's now examine one of the most well-documented genotype-phenotype associations, the Val122-IL mutation, which illustrates the cardiac dominant form of hereditary transthyretin amyloidosis. This mutation is especially relevant in individuals of African ancestry. In fact, valine 122-isoleucine is found in approximately 3 to 4% of African Americans, making it a significant variant in this population group. Clinically, it tends to manifest later in life, typically after the age of 65, and is characterized by heart failure with preserved ejection fraction, or HFpEF, restrictive cardiomyopathy, left ventricular hypertrophy, and various cardiac conduction abnormalities. While the phenotype is predominantly cardiac, some individuals may also experience carpal tunnel syndrome or peripheral neuropathy, features that may precede cardiac symptoms by several years. Key clinical implications for Val122Y in African populations include: it is frequently misdiagnosed as hypertensive heart disease or age-related cardiomyopathy. This underdiagnosis often results in treatment delays and leads to poorer clinical outcomes. Therefore, targeted genetic screening and phenotype-guided surveillance are essential, especially in high-risk populations. Recognizing the significance of Val122-IL allows clinicians to intervene earlier, refine diagnostic accuracy, and ultimately improve patient outcomes through timely, mutation-specific management. To round out our understanding of genotype-phenotype correlation in transthyretin amyloidosis, let's take a closer look at the symptom profiles observed across the major phenotype categories. This comparative table highlights the relative frequency of key clinical features in 4 common genotypic groups: Val30, met early onset; valine 30-methionine late onset; non-valine 30-methionine cardiac mutations, such as valine 122-isoleucine, and non-valine 30-methionine mixed phenotypes. Here's how to interpret the table. The number of plus signs, plus, reflects the likelihood of symptom presence. A symbol like plus means that symptom expression is variable, it may or may not be present. And as a reminder, CTS refers to carpal tunnel syndrome and GI refers to gastrointestinal symptoms. Let's walk through some highlights. In Val30-Met early onset cases, patients frequently present with neuropathy, autonomic dysfunction, and GI involvement. This phenotype tends to be neurologic dominant, often seen in endemic regions. For late-onset valine 30-methionine, the profile shifts slightly. Cardiac symptoms become more prominent, while neuropathic signs are still common but appear later and more subtly. In contrast, mutations like valine 122-isoleucine, representing the non-valine 30-methionine cardiac phenotype, are marked by severe cardiomyopathy and conduction disturbances, while neurologic symptoms are minimal or absent. Lastly, the mixed phenotype presents a broader spectrum of both cardiac and neurologic involvement, with intermediate likelihoods across all categories. Understanding these distinctions is essential. It enables accurate clinical suspicion, informs diagnostic strategy, and ensures phenotype-specific monitoring. Now let's turn to one of the most powerful diagnostic and prognostic tools in modern cardiac amyloidosis care, genetic testing. 1. Clinical utility in early diagnosis and risk stratification. Genetic testing is a cornerstone in diagnosing and managing hereditary transthyretin amyloidosis, also known as ATTRv. It allows us to detect pathogenic variants in the TTR gene well before clinical symptoms emerge. This is especially important in the current era of disease-modifying therapies, where early identification of mutation carriers enables timely intervention, risk stratification, and familial screening. Take, for instance, the valine 122 isoleucine mutation, highly prevalent in African populations. Early detection through genetic testing, followed by routine cardiac imaging and biomarker surveillance, can dramatically improve heart failure outcomes and extend quality-adjusted life expectancy. 2. Applications in family planning and predictive care. Beyond individual care, genetic testing also plays a pivotal role in family planning. When a pathogenic TTR variant is detected, predictive testing can be offered to at-risk relatives. This not only informs reproductive choices, but also supports early surveillance and preventive strategies across generations. Furthermore, genotype-specific insights allow us to tailor follow-up care. Carriers of neurologic dominant mutations like valine 30 methionine benefit from early neurologic assessment. Those with cardiac dominant mutations, such as valine 122 isoleucine, are better monitored using echocardiography, strain imaging, or bone scintigraphy. 3. Ethical and psychosocial implications of genetic testing. However, this powerful tool is not without ethical and emotional complexity. Being told you carry a mutation, especially with uncertain onset or severity, can provoke anxiety, depression, or decisional conflict. It also places a burden on individuals to notify at-risk family members. The psychosocial ripple effects are significant. This is why pre- and post-test genetic counselling is essential. Patients must understand what their results mean, what choices they have, and how to cope with the emotional aftermath. Testing in children presents additional challenges. Most guidelines advise against predictive testing in minors unless early intervention could alter disease course. Respecting a child's autonomy and emotional development remains paramount. Finally, direct-to-consumer testing, expanding access, raising concerns. The rise of platforms like 23andMe has expanded access to TTR screening, but these services, while accessible, often lack clinical oversight. While they can detect common mutations, such as valine 122 isoleucine, valine 30 methionine, or threonine 60 alanine, they frequently miss rare but clinically significant variants. And many users are unprepared for the emotional and medical consequences of a positive result without appropriate counselling. In summary, genetic testing is foundational in ATTRv management. When supported by multidisciplinary care and comprehensive genetic counselling, it enables early diagnosis, personalised monitoring, and empowered family decision-making. As genetic insights continue to evolve, their integration into clinical practice will remain vital to improving outcomes for patients and their families. Diagnosing hereditary transthyretin amyloidosis isn't just about running a genetic test. It's about building a structured, supportive pathway for patients and families. Genetic results must be carefully interpreted, emotionally supported, and integrated into long-term care. That's why a multidisciplinary approach is essential, especially when managing asymptomatic first-degree relatives of mutation carriers. A widely endorsed model for this process was introduced by Alresch and Ruberg in 2021. It outlines a three-phase clinical workflow designed to guide clinicians and patients through every step of the genetic testing journey, from initial counselling to long-term surveillance. Phase 1, pre-testing. This first phase centres on identifying individuals at genetic risk and preparing them emotionally and clinically before testing. There are three main pillars here. First, consent. Testing should always be initiated by the patient and conducted by trained professionals. It's crucial that individuals understand the potential benefits of identifying a TTR mutation, especially now that we have disease-modifying therapies that can change the course of the illness. Second, timing. Here, timing is everything. We generally avoid testing minors unless there's a strong justification for early intervention. Instead, we use a concept called predicted age of disease onset, or PARDO. This is determined by genotype, family history, and symptom onset in affected relatives. Expert consensus suggests beginning surveillance about 10 years before the estimated onset window. Third, counseling. This step is absolutely essential. Genetic counseling, ideally offered in more than one session, helps individuals understand the meaning of test results, the emotional impact, and what the implications might be for other family members. Mental health support should always be available at this stage. Phase 2, during testing. Once a patient provides informed consent and is emotionally prepared, the actual genetic testing is performed. This should always involve a multidisciplinary team, including a cardiologist, a neurologist, a medical geneticist, and a mental health professional. In complex cases, an ATTR amyloidosis specialist may also be consulted. And importantly, test results should never be given over the phone or via email. They must be delivered in person, ideally during a dedicated consultation with plenty of time for discussion, questions, and emotional processing. Phase 3, post-testing. This final phase separates into two possible paths, one for patients who test negative and another for those who are asymptomatic mutation carriers. Let's look at the path for asymptomatic carriers first. These individuals need a long-term clinical follow-up plan that's proactive, structured, and multidisciplinary. This includes history and clinical examination to identify neuropathic, autonomic, or cardiac symptoms. Cardiac screening, ECG, echocardiography, biomarkers like NT-proBNP and troponins, and when needed, advanced imaging like technetium, 99M pyrophosphate, PYP, scintigraphy, or cardiac MRI. Neurologic screening, EMG, nerve conduction studies, skin biopsy, and neurology referral, especially for genotypes associated with neuropathic forms of ATTR. Follow-up is typically annual, starting about a decade before the predicted onset based on family history and genotype. And remember, we're not only focused on the individual. Cascade testing should be discussed for at-risk relatives. Now, for those who test negative, that doesn't mean their journey ends. Psychological support may still be important, especially if there's been long-term anxiety about inherited disease risk. Ongoing access to counselling can help these individuals process their results and support family members who may still be navigating testing decisions. As you can see in this visual from Alresch and Ruberg, the entire process is designed to be comprehensive, ethical, and patient-centered. By integrating genetic counselling, appropriate testing, and long-term monitoring, we can move toward earlier detection, more timely treatment, and ultimately better outcomes for those with hereditary ATTR. And this is especially important for high prevalence and underdiagnosed groups, such as individuals of African ancestry with the valine 122 isoleucine mutation, where proactive surveillance can be life-saving. As we wrap up this lesson on genetic testing in transthyretin amyloidosis, let's take a moment to reflect on what we've covered. Genetic testing is far more than a laboratory tool. It's a gateway to early diagnosis, risk stratification, and generational care planning in hereditary ATTR amyloidosis. We explored how genotype influences phenotype, including the cardiac dominant valine 122 isoleucine and neurologic dominant Val30met mutations. We also reviewed the structured three-phase approach to managing asymptomatic carriers, emphasizing the importance of pre-test counseling, baseline screening, and long-term monitoring. Importantly, we discussed the ethical, emotional, and familial considerations that must guide our use of genetic testing, ensuring that results are delivered with empathy, clarity, and clinical actionability. And as we saw, combining genetic insight with clinical surveillance enables truly proactive care, empowering individuals and families to make informed decisions and prepare for what lies ahead.